I work nowadays in Riyadh, King Faisal Hospital in Saudi Arabia, and I have no conflict of interest regarding this presentation. As you know, I cannot in 10 minutes cover all the aspects of amyloidosis. I have 669 slides, but I will try to focus on the main point. So amyloidosis is a group of disease that is due to extracellular deposition of insoluble amyloid fibrils. Amyloid heart disease is often underdiagnosed or misdiagnosed everywhere in the world, not only in Riyadh, not only in France, everywhere, because it can simulate many other diseases, and clinical manifestations actually are misleading and depends on the of amyloid deposit. Its diagnosis implies integrative approach using clinical clues, EKG, echo, and sometimes MRI, and multimodality imaging, and sometimes tissue biopsy is mandatory to reach the diagnosis. However, please remember, a high index of suspicion is the key to find this patient. There's more than 20 precursors of amyloidosis that can create the disease. I want you to remember only two. At the left side, the blue, the transthyretin amyloidosis, which can be either hereditary one or the acquired one with the elderly. We used to call it senile amyloidosis in the past, which gives the position of wild-type transthyretin. And the hereditary one, it's due to autosomal dominant disease in chromosome 18 and due to deposition of mutant transthyretin. Both this one are due to liver abnormalities. It's a liver disease. On the right side, you have the light chain amyloidosis. It's a toxic disease. It's a hematological disease, and due to deposition of light chain due to plasma cell dyscrasia. Basically, you have a plasmacyte monoclonal things in the bone marrow that gives toxic component M monoclonal component that takes light chain. Light chain are very toxic for the heart and for the organism, and they misfold and they give amyloid fibrils in many organs. Just again, I'm telling you this is very important. Please remember, light chain amyloidosis is an acute disease. It kills people. It has to be treated and it needs to be urgently diagnosed because the survival is 4 to 6 months if the patient presents already with heart failure. On the right side, ATTR is more kind of chronic disease. It's less urgent to diagnose, and the median survival is 4 to 6 years if untreated. So please remember, I want you to really recognize the light chain amyloidosis. We can save lives. However, the diagnosis of amyloidosis is not straightforward. I mean, it's not like a COVID, you do PCR, you have the disease. Here, you need to have put things together. I call it like a puzzle. You need echo, EKG, PYP, MRI, clinical assessment, lab tests, biomarkers, sometimes tissue biopsy. Okay, this is a slide. It comes from the JAC 2003, and you can see that the clinical manifestations are very diverse with ATTR cardiomyopathy. It can be a cardiac manifestation, musculoskeletal, polyneuropathy, autonomic dysfunction, and that's why it leads to errands of the patient. It goes from doctor to doctor. They travel everywhere, and they see basically almost in 50% of the case 5 doctors before they reach the diagnosis. I give you more images here because extra cardiac signs are very important. We know we're all cardiologists here, and we don't have the time to examine the patient. But remember that extra cardiac signs have a very good positive predictive value in the setting of unexplained dyspnea and suspicious echo. On the left side, again, I put you the signs that are more likely associated with light chain amyloidosis, the ecchymosis, the soft tissue manifestation, the nephrotic syndrome, the lung edema, all the things, and the macroglossia that are more likely to be with light chain, and the other things with ATTR, the musculoskeletal manifestation, the spontaneous rupture of the tendon. You will be very proud in front of your resident if you do this and you will make the diagnosis, because not many diseases give you this rupture spontaneous tendon. The carpal tunnel syndrome, ask the patient if he has surgery before. And in the middle, you have the common one, the orthostatic hypotension or the peripheral neuropathy. So I know there is a lot of information, but remember 3 things. If you have cardiomyopathy, neuropathy, and nephrotic syndrome, both together, remember it's light chain until otherwise proven. You have to demonstrate that it's here or to rule it out. On the other side, if you have a heart failure unexplained, neuropathy, carpal tunnel syndrome, and hypotension, remember it could be ATTR, and do PYP scan to rule out this disease. Really, really, it's important. Now, this is just to give you an idea because I'm passionate about echo and I love echo. Look, this is ATTR damage and this is light chain damage. This occurs over years and this is occur over months. You can see that the thickness of the heart is much less in the light chain because the patient does not have the time to live enough to be thick at up to 18. So basically around 12 to 30 millimeter. But the damage are almost the same, but it's a kind of time. Okay, now the key electrical findings is the relative low voltage. What means relative low voltage is discordance between LV wall thickness and the QRS voltage. You have to put always the echo and the EKG together, and you read that one together. And there is, the QRS voltage is lower than expected for the LV wall thickness. I put you here, this is, we call it again, I will give you another. This is other sign. The most frequent sign in ATTR is the pseudo-infarct pattern in V1, V2, V3. It looks like somebody who has myocardial infarction, but actually is a chronic over time, and the troponin, you don't have the same kinetic over time. Now, many people, and we learn this in medical school, you have the absolute low QRS voltage. It's not very common, actually. It's more common in the light chain, and actually it's more a sign that late stage of the disease. In other words, we wait too long to diagnose the patient, and they may have the absolute QRS low voltage. Now you have, of course, unexpected conduction disturbance, arrhythmia, atrial fibrillation in 50% of the case, LBB, left bundle branch block, AV block. LV hypertrophy is rare. However, you can have an EKG like 10 to 20% of the patient. So remember, pseudo-infarct pattern, atrial fibrillation, and relative low voltage. Now, I cannot talk about echo. I can talk for 2 hours. I will summarize on one slide all the signs that you need to know in cardiac amyloidosis. It's severe heart failure, contracting with apparently normal ventricles, blindly diffuse deposit of the amyloid fibril everywhere, LV, RV, IVS, valves. Impairment of the LV long axis. Remember, this is very important. When you have small S wave, small MAPC, and you have a low GLS, all the sign, they have a good sensitivity and specificity for differentiating cardiac amyloidosis from other type of disease of hypertrophic state. And you have to calculate sometimes the apical to base ratio. You have also small pericardial effusion in 50% of the case, and you have pulmonary hypertension, and it depends actually on the stage when you discover the disease. You can have high RA field pressure, high LA field pressure, high PA pressure, and low stroke volume. This is alteration are almost here when you discover this patient. Now, what about aortic stenosis and ATTR? I cannot talk about all the study. I summarize for you everything. Basically, associate aortic stenosis with ATTR is present in 8 to 15% on those undergoing TAVI population. The mean age are higher than the AOS alone, 80 years. 70% of them are male, and most of the time they present with low flow, low gradient aortic stenosis. So it's a very common condition now, and we are counting between, and our experience is around 10% of the population. Now, when we are talking this morning with Dr. Hussam about this diagnostic value of CMR, it's a good, I call it, it's a super powerful echo. It has a good resolution, and it gives you the same morphological information as echo in terms when patient is very acoustic, have acoustic window, and also it gives you tissue characterization, of course, which echo cannot give. All pattern of late enhancement are possible in this disease. You can have the patchy, you can have the transmural, you can have the subendocardial. The thing that's very important is the short inversion time, suboptimal nulling. This is very common in this disease, and the radiologist is not able to try to find this time. The most common and the most, modern things is to look at the T1 mapping and the extracellular expansion. And when you have a T1 mapping more than 1164, it's really diagnosis at 92% of the case of the disease. So look at this sign if the other sign is not good. Now, when you should use hematological test and biomarker, they should be done actually for every patient with suspected cardiac amyloidosis. The free light chain, the serum and immunofixation, the abnormal kappa over lambda, and of course the troponin and BNP can give you a prognostic staging of the disease, especially in light chain amyloidosis. Finally, the bone scintigraphy of the heart is a cornerstone in ATTR. It has a very good sensitivity and specificity, more than 92% for detecting ATTR, and it does not diagnose light chain. Remember, they don't bone for the calcium. It helps distinguish between ATTR and light chain and other disease, and grade 2 and 3 uptake confirmed by SPECT imaging. And if you are able to rule out plasma cell dyscrasia, is diagnostic of ATTR, and we don't need to do any cardiac biopsy for this patient. In other words, it has a 100% positive predictive value. But I want you to remember, you have to have the planar imaging. This was the mistake many years. If you have a planar showing uptake, you have absolutely to do a SPECT imaging to cut the heart in transversal and to see that the uptake is in the myocardium, not in the cavity block. So the ratio is, sorry. Okay, I'm done, actually. When should you perform tissue biopsy in cardiac amyloidosis? You have to do biopsy to prove the presence of light chain amyloidosis only in light chain. You don't have to do it for TTR because you cannot give chemotherapy for this patient. You don't have to do cardiac or renal. You can do subcutaneous, fat, rectal, accessory, salivary, whatever your center is good on it. And you have to type the original protein should be performed as mass spectrometry because you cannot treat ATTR as light chain and vice versa. Actually, when you should perform genetic testing, and this is my almost final slide, differentiate between wild type and hereditary ATTR, differentiate between light chain and other amyloidosis subtype, phenotype and genotype correlation, and family screening. So as you can see that the timeline, the best time to diagnose patient, and when you look at the orthopedic manifestation, and that time the prognosis is much better than when you look at the clinical dyspnea, heart failure, or something which is goes at the up. Echo and EKG are unfortunately late on the line of the diagnosis. Remember, the earlier the better. If we are able to see patient at the stage of carpal tunnel syndrome or orthopedic manifestation, you have better treatment and you can, rather than stage C. In summary, my friends, please have a high index of suspicion. Look at the clinical clues, cardiac and extracardiac sign. Suspicion phase involve echocardiography, EKG, sometimes MRI. The homological workup is mandatory for everybody, and the confirmatory phase implies bone scintigraphy of the heart, tissue or heart biopsy, and please treat as soon as possible. You have for the first time guidelines, typical guidelines in European Heart Journal to tell you the role of each parameter and each testing and according to the guide. I don't have the time to go through it, but really it's what I told you. And actually you have also the consensus European from Pablo Garcia, and you have even the American now. Everybody is running after amyloidosis now. So it's really gaining a lot of interest because of the new treatment we have. So the journey of cardiac amyloidosis is very long, and you need to work with your colleague. You cannot work on yourself. You have to work with the hematologist. You have to work with nephrologist. You have to work with all the other people, and you have to create in your center a cardiac amyloid team, as we did in Riyadh. And because if you want to go fast, you have to go far, you have to go with other people. So please create your own team. Not everybody is involved in amyloidosis. Not everybody likes this disease. So you have to choose your own people whom you want to work. And take-home message, work as a team. Look for clinical clues. Look for echo, EKG, sometimes MRI. Order bone scintigraphy, protein immunofixation, and discuss supportive and disease-modifying treatment according to the country. And please, please have a high index of suspicion. If you don't think about it, you will never diagnose it. Thank you so much.